The upper limb muscles fall into three groups. The first group of muscles arises from the shoulder girdle and cross the shoulder joint to insert into the humerus. These muscles move the arm. The second group causes movement at the elbow joint, and most arise from the humerus and insert on the forearm bones. The third group includes the muscles of the forearm, which insert on the wrist, hand, and fingers. The first group of muscles that we will examine are the superficial muscles of the anterior and posterior thorax. These muscles are responsible for moving the scapula and consequently the upper limb. These muscles are known as the extrinsic shoulder muscles because they run from the ribs and vertebral column to the pectoral or shoulder girdle. They have two primary functions, either to fix the scapula in place or to move the scapula so that the range of motion of the upper limb can be increased. The anterior muscles include the pectoralis major and minor, serratus anterior, and subclavius. The posterior muscles include the latissimus dorsi and trapezius, and the underlying levator scapulae and rhomboids. The subclavius is a small muscle that extends from the first rib to the underside of the clavicle green arrow. It helps to stabilize and depress the pectoral girdle to allow for precise movements of the upper limb. The pectoralis minor blue arrow draws the scapula forward and downward when the ribs are fixed. However, if the scapula is fixed, contraction of the pectoralis minor pulls the rib cage superiorly. Thus, the pectoralis minor muscle can be considered an accessory muscle of forced inspiration. Patients suffering from chronic obstructive pulmonary diseases such as emphysema will extend their upper limbs against a tabletop to fix the scapula, and use the contractions of the pectoralis minor muscles to help them breathe. The serratus anterior gets its name from its jagged or sawtoothed appearance. Its origin is from slips of muscle arising from the first 9 ribs. These join together to insert on the entire anterior surface of the vertebral border of the scapula. The main action of the serratus anterior is to rotate the scapula so that the inferior angle moves laterally and upward. This rotation of the scapula allows you to raise your arm above your head. The serratus anterior also works to protract and hold the scapula against the posterior rib cage, and permits arm movements such as pushing or punching. That's why it is nicknamed the boxer's muscle. The trapezius is a superficial, flat triangular muscle extending from skull and vertebral column medially to the pectoral girdle. The two trapezius muscles form a diamond on the superficial back. The action of the trapezius depends on which region of this large muscle is active. The middle fibers retract or adduct the scapula. The superior fibers elevate the scapula and work with the levator scapulae to shrug the shoulders or can help extend the head when the scapula is fixed. The inferior fibers depress the scapula and shoulder. The levator scapulae lie deep to sternocleidomastoid and trapezius. These muscles work along with the superior fibers of the trapezius to elevate the scapula as when shrugging the shoulders or lifting a weight over the head. The rhomboids stabilize the scapula and work with the middle fibers of the trapezius to adduct the scapula as when squaring the shoulders. Muscles that cross the shoulder joint move the humerus. There are a total of 9 of these muscles, however. Only the pectoralis major, latissimus dorsi, and deltoid muscles are prime movers of the arm. The remaining 6 muscles act as synergists and fixators. 4 of these make up the rotator cuff. In addition, only the pectoralis major and latissimus dorsi do not arise from the scapula. The above illustration shows the pectoralis major and latissimus dorsi muscles. The only 2 of the 9 muscles that cross the shoulder joint that do not arise from the scapula. The pectoralis major is a large, flat muscle with convergent fibers that have multiple origins from the clavicle, sternum, costal cartilages of ribs 1 to 7, and the aponeurosis of the external oblique muscles. The fibers converge to insert by a short tendon into the intertubercular sulcus and greater tubercle of the humerus. The pectoralis major muscle is a prime mover of arm flexion, medial rotation, and adduction. It functions when climbing, throwing, pushing, and in forced inspiration. The latissimus dorsi is a broad, flat, triangular-shaped muscle with numerous origins from the lumbodorsal fascia, spines of the 6 inferior thoracic vertebrae, lower 3 to 4 ribs, and iliac crest with a bit coming from the inferior angle of the scapula. The latissimus dorsi inserts on the intertubercular sulcus of the humerus. This muscle is a prime mover of arm extension, and so in this action it is an antagonist of the pectoralis major. It is also a powerful arm adductor and medially rotates the arm at the shoulder. It functions in common activities such as hammering, swimming, and rowing. The remaining 6 muscles are called scapula muscles because they have their origins on the scapula. Of these, only the deltoid is considered to be a prime mover of the arm. The deltoid is a thick, triangular-shaped multipectinate muscle. It has a complex origin with fibers arising from the lateral third of the clavicle, acromion, and spine of the scapula. It is the prime mover of arm abduction when all its fibers contract simultaneously. It is an antagonist of the pectoralis major and latissimus dorsi, which adduct the arm. When only the anterior fibers are active, the deltoid can be a powerful flexor and medial rotator of the arm. However, if only the posterior fibers are active, the deltoid assists in arm extension and lateral rotation. It is also active in the swinging of our arms when we walk. The remaining muscles are collectively referred to as scapula muscles because they have at least part of their origin on the scapula. These muscles are the deltoid, which functions in abduction at the shoulder when the entire muscle contracts, flexion and medial rotation when only the anterior part acts, and extension and lateral rotation when the posterior part contracts. The teres major helps to form part of the posterior axillary wall. It extends, medially rotates, and adducts the arm. The coracobrachialis functions in flexion and adduction of the arm and is a synergist of the pectoralis major. A nerve called the musculocutaneous pierces its belly. This nerve supplies forearm flexors. The remaining 4 scapula muscles make up the musculotendinosus cuff, more commonly known as the rotator cuff. These muscles work stabilize the pectoral girdle. The strength and stability of shoulder is because of these 4 deep muscles. They are the subscapularis, supraspinatus, infraspinatus, and teres minor. The subscapularis fills the subscapular fossa and forms part of the posterior wall of the axilla. It inserts on the lesser tubercle of the humerus and is the chief medial rotator of the humerus. The subscapularis helps to hold the head of the humerus in the glenoid cavity. The supraspinatus prevents downward dislocation of the humerus and initiates abduction. This muscle is found in the supraspinous fossa of the scapula, deep to the trapezius. It inserts on the greater tubercle of the humerus. The infraspinatus arises from the infraspinous fossa and inserts on the greater tubercle of the humerus. It acts to rotate the humerus laterally and to hold the head of humerus in the glenoid cavity. The teres minor muscle is often inseparable from the infraspinatus. It originates from the lateral border of the dorsal scapula and inserts on the greater tubercle. It has the same action as the infraspinatus. Because of the nature of our highly mobile but unstable pectoral girdle, shoulder injuries are common and are not only restricted to athletes. There are many kinds of injuries involving the pectoral girdle, such as dislocation of the humerus, broken labrum, bursitis, but injury to the rotator cuff is one of the most common. Rotator cuff, also known as impingement syndrome, results from making repetitive overhead motion. This results in continual pinching of the supraspinatus tendon, resulting with inflammation, pain, and eventual degeneration which can cause the muscle to pull away from the humerus. Since the elbow is a hinge joint, movements from contracting these muscles is almost entirely limited to flexion and extension. The forearm is divided by deep fascia into two muscle compartments. The anterior compartment contains the flexors and their nerve innervation and blood supply, and the posterior compartment contains the extensors and their nerve and blood supply. The muscles in these compartments are antagonists to each other. When flexors contract, the extensors must relax or the elbow would not bend. The picture above on the left shows a transverse section through the brachium and reveals the positions of muscles in the anterior flexor compartment and posterior extensor compartment. The other picture shows an anterior view of the superficial layer of muscles in the upper limb. Locate the long and short heads of the biceps brachii. The short head originates from the coracoid process, and the long head arises from the glenoid tubercle of the scapula-supraglenoid tubercle. The bellies of both heads fuse and insert on radial tuberosity and bicipital aponeurosis. The biceps brachii spans both the shoulder and elbow joint. It flexes forearm at elbow joint and arm at the shoulder joint, and it supinates the forearm at the radioulnar joints via the bicipital aponeurosis. It turns the corkscrew and pulls out the cork. The brachialis lies deep to the biceps brachii. It is actually the strongest of the forearm flexors. It arises from the distal end of the humerus and inserts on the coll-rhonoid process of the ulna. The brachioradialis is a superficial muscle of the lateral forearm and forms the lateral boundary of the cubital fossa extending down to the distal forearm. It originates above lateral epicondyle of humerus and inserts on the styloid process of radius. This muscle is a synergist in forearm flexion and works best when the forearm is partially flexed. It also helps to stabilize the elbow during rapid flexion and extension. The triceps brachii is a powerful muscle of forearm extension prime mover. It has three heads. The long head comes from the infraglenoid tubercle of the scapula, the lateral head from the posterior shaft of the humerus, and the medial head from the posterior humeral shaft distal to the radial groove. All three heads insert a common tendon into the olecranon process of the ulna. The anconeus is a short, triangular muscle whose name means elbow. It runs from the lateral epicondyle of the humerus to the lateral aspect of the olecranon process of the ulna. It controls ulnar abduction during forearm pronation. Examine this slide. It is very helpful in showing the compartments that the arm muscles occupy and their actions on forearm movement. The muscles in the forearm perform several functions, such as wrist movements, movement of the fingers and thumb, and a few help pronate and supinate the forearm. The fleshy part of these muscles are found in the proximal forearm. They are characterized by having long tendons that attach at the wrist, metacarpals or digits. These tendons are anchored in place by deep fascia called the flexor and extensor retinaculum, which keep the tendons from jumping outward when tense. They are also surrounded by slippery tendon sheaths that minimize friction. There are 8 muscles found in the anterior facial compartment, which are listed in the above slide from lateral to medial. Most arise from a common flexor tendon attached to the medial epicondyle of the humerus. The forearm flexors and the pronator teres share a common origin from the medial epicondyle of the humerus. The pronator teres inserts into the lateral radius at about midshaft. The flexor carpi radialis is a powerful flexor of the wrist, and it also abducts the hand. It inserts on the base of the second and third metacarpals, and its tendon is used as a superficial landmark to find the position to take the radial pulse. The palmaris longus is a small muscle with a long tendon that inserts on the palmar aponeurosis, the thick fascia of the palm. It is absent in about 10% of the population, but when present, it is used as a guide to find the median nerve, which lies just lateral to it. The flexor carpi ulnaris is also a powerful flexor of the wrist, but it adducts the hand. Its insertion is on the pisiform, hamate, and base of the fifth metacarpal. The flexor digitorum superficialis flexes the wrist and middle phalanges of fingers 2 to 5. It inserts by 4 tendon into the middle phalanges of fingers 2 to 5. In order to more clearly see some of the intermediate forearm muscles, the brachioradialis, flexors carpi radialis, and ulnaris and palmaris longus muscles were removed so that the flexor digitorum superficialis can be seen more clearly. Notice the insertion into the middle phalanges of fingers 2 to 5. In this view, the flexor digitorum superficialis has been removed so that the deepest muscle layer in the compartment can be seen. The flexor digitorum profundus arises from the coronoid process of the ulna and interosseous membrane, and inserts by on the distal phalanges of fingers 2 to 5 by passing under the insertion of the superficial muscle. The flexor pollicis longus originates from the anterior surface of the radius and interosseous membrane, and inserts on the distal phalanx of the thumb. The pronator quadratus is the deepest muscle of the distal forearm. It arises from the distal portion of the anterior ulnar shaft and inserts on the distal surface of the anterior radius. It is the prime mover of forearm pronation. The muscles of the posterior compartment are listed from lateral to medial. They are all innervated by the radial nerve or branches from it. More than half of the posterior compartment muscles arise from a common extensor tendon attached to the lateral epicondyle. The extensor tendons are held in place on the wrist by the extensor retinaculum, which prevents them from bowing out when the wrist is hyperextended. There are 4 superficial muscles and 4 deep muscles in the posterior or extensor compartment. The extensor carpi radialis longus originates from the lateral supracondylar ridge of the humerus and inserts on the base of the second metacarpal. In addition to extending the wrist, it also abducts the wrist in conjunction with the flexor carpi radialis. The extensor carpi radialis brevis lies deep to the longus. Its origin is on the lateral epicondyle of the humerus, and it inserts on the base of the third metacarpal. It also extends and abducts the wrist. The extensor digitorum arises from the lateral epicondyle and inserts the 4 tendons into the extensor expansion and distal phalanges of fingers 2 to 5. A small detached portion of the extensor digitorum extends the little finger and is called the extensor digiti minimi. The extensor carpi ulnaris is the most medial of the superficial posterior muscles. It arises from the lateral epicondyle and posterior border of the ulna and inserts on the base of the fifth metacarpal. It extends the wrist and adducts it in conjunction W. If the flexor carpi ulnaris. With the superficial muscles removed, the deep muscles of the posterior compartment, as well as the interossi, which are the deepest of the intrinsic hand muscles, are visible. The supinator originates from the lateral epicondyle and proximal ulna and inserts at the proximal end of the radius. It assists the biceps brachii to forcibly supinate the forearm. The abductor pollicis arises from the posterior surface of the radius and ulna and inserts on the base of the first metacarpal and trapezium. It acts to abduct and extend the thumb. The extensor pollicis brevis and longus arise from the radius, ulna, and interosseous membrane, and inserts on the base of the proximal brevis and distal longus phalanx of the thumb. As the name indicates, they extend the thumb. The extensor indicis is a tiny muscle that arises from the posterior surface of the distal ulna and interosseous membrane. It inserts on the extensor expansion of the index finger and joins the tendon of the extensor digitorum. It extends the index finger. As mentioned previously, the tendons and blood vessels are held close to the bones of the wrist by tough fascia. This deep fascia is thickened into fibrous bands called the flexor retinaculum equal transverse carpal ligament. The transverse carpal ligament is located over the palmar surface of the carpal bones. the long flexor tendons of the digits and wrist, along with the median nerve pass through this retinaculum. A common injury to this area is carpal tunnel syndrome, which results from repetitive motion of the fingers, thumb, and wrist, which eventually causes inflammation. The swelling and results of the inflammatory response compresses the median nerve, which controls the thumb and 2.5 fingers. The severe pain of carpal tunnel syndrome can be relieved by cutting the flexor retinaculum to remove the pressure. There are other causes of carpal tunnel syndrome, but this is one of the most common. This is a great slide to summarize the actions of the different forearm muscles and to explain the concept of compartments.